Well, good evening, everyone. Welcome back again to our Exam Pro webinar sessions for the 2020 ABOG Boral exams. I'm your host for this evening, Rob Pegues. Particular welcome to our candidates who are joining us this week in Baltimore for our second oral board preparation course and our first completely in-person live course in 2 years. We're very happy about that. We are, since it's Sunday, doing case list review and defense discussions. Let's get right to that since we have 4 of our candidates there, and I think perhaps a couple more to come up. As we have been doing, please do click the raise your hand button. I have actually behind me, I think, all of our case lists loaded up here. I do, just a second. There they are. And we will get right to this. So we should have, since we have a fairly small group for this evening, we should be able to get everybody have a chance to get a case list discussion. So please do click the raise your hand button if you'd like to take a look at one of your cases, or I'll be happy just to go down the list and we'll kind of call on everybody. Maria, thanks for joining us and for chiming in. We'll get you unmuted here for a moment. There we go. Hi, Maria, welcome back.
Hi.
Hey, let me get your case list up here. Anything particular that you look at that you have been looking at that you'd like to discuss this evening?
No, anything that you want to grab, I guess.
Okay, that's fine. Do you have a preference for OB/GYN or office practice?
I don't.
Okay, well, let's see. Hey, and thank you, Ebony. We'll be with you in just a second. Let's see. Oh, we'll do maybe GYN. Just let's see. Pop up something and see what we have going on here. Let's see. See what we have here. Sure. Let's take case number 2, maybe your first big abdominal hysterectomy.
Okay.
Is that okay? Let's see. So let's see. We have a pretty big uterus here. Let's see. I'm curious, actually, briefly into when you have like 1,280 gram uterus, what your failed medical management consisted of, but we might come to that in a minute. I would say in these big complicated cases, it's actually fairly easy for them to sort of make up hypothetical complication things to talk about. And in this case, they might do something like, let's see, in the course of performing this hysterectomy, you have a very large fibroid uterus, including some lower segment myomata. In this case, I'm assuming you're dissecting the endopelvic fascia between the cervix and the bladder, the cervico-vesical junction, and you identify your Foley catheter and realize that you have incurred an incidental cystotomy. What would be your initial step in evaluating this situation?
I would determine where the cystotomy was located on the bladder.
How would you do that?
Well, if I was based on, well, I guess what I was seeing.
Okay, if you are dissecting the at the cervico-vesical junction, you have a cystotomy. Where probably in the bladder are we?
At the cervical, I'm hoping the dome.
Is the bladder dome at the cervico-vesical junction?
Probably
Unfortunately not. It's not, no.
that would
when we're down in that area, what part of the bladder are we
in? Oh goodness. The name is escaping me right now, of course, because I'm on the hot seat, but
okay.
Midway down.
Would you agree that we'd be close to the trigone, if not at the trigone?
Yes.
That's good. Okay, good. So based on that, and you're exactly right. Your first step should be to evaluate where in the bladder we are. How would you evaluate this? What important information would you want to determine as quickly as possible in this case?
I mean hemodynamic stability.
Yes. Let's say for simplicity that there's actually a little tiny bit of bleeding, but not much, especially just that there's a cystotomy. And you can see the Foley catheter kind of poking through the bladder.
Okay. And the size of the cystotomy and the anatomy of the bladder?
Let's say 1.5 centimeters transverse across just kind of along the line where you're dissecting the cervix.
Okay. And how much of the bladder had been dissected off during my process of the hysterectomy at that point? Because I guess I would want to decide, would I proceed with the hysterectomy right now or potentially call for urology for, well, I would absolutely be calling for urology at the moment that I recognize the cystotomy. and determining when I would repair the cystotomy.
Okay. Well, I'm going to let you make the call. What do you want to look at the cystotomy now, or do you want to complete your hysterectomy?
With 1.5 centimeters, I would see if I would be able to dissect the rest of the bladder off to complete the hysterectomy and repair the cystotomy at the end if everything else was favorable.
Okay. Before you do that, is there any important information that you would want to determine before you proceeded to sort of leave this in place here?
Well, where the course of the ureters are.
Right. Tell me about that. What specifically do you want to look at here?
Well, with large fibroid uteruses, the course of the ureters can be unpredictable because the fibroids can distort the anatomy.
True. Well,
So
where at this moment, where are you concerned about the ureter?
near the uterine artery.
Really? Okay.
Am I too high up?
No, I mean that's okay, but what we're dealing with is an opening into the bladder. So seriously, are you worried about the ureter in the pelvic sidewall at this point?
No, I'd probably be worried about where the ureters enter into the bladder.
Ah, right. So we're in the trigone of the bladder. What are we looking for? You can actually see into the bladder because you can see your whole Foley catheter bulb in there. What would you be looking for inside the bladder at this point?
I mean, the ureters to see if I can see like
Yeah,
peristalsis.
what part of the ureter can you see inside the bladder? Because you can actually look into the bladder at this point.
Like the ureteral jets, I guess.
Yes, the ureteral orifices, exactly. And
Mm.
with the cystotomy that sort of goes crossways on the bladder at the trigone, what really important information do you want to assess at this point?
How much damage was done, if any, to the ureters?
Exactly. Where are the ureters relative to your cystotomy? And is there any chance that we might also have a ureteral injury on one or
Mhm.
both sides instead of just a bladder injury? Exactly. So you're going to look into the bladder. And to the best of your knowledge, you can actually see you're above the level of the ureteral orifices by a little bit, maybe several millimeters or so, but you can actually see the ureteral orifices, and there may be urine draining from them. What would you do at this point?
Well, if I was going to proceed with a repair of the cystotomy, I would attempt to close it in 2 layers.
Mm-hmm.
And if I remember correctly, I would attempt to close it after I called urology, of course, and assuming they're not available, and I'm going to go ahead and repair this on my own.
No, yeah, we'll let you have urology.
I'm sorry?
We will let you have urology in this case.
Oh, okay. Then I have them come in and I would assist them in the repair. And then after the repair was finished, I'm sure we would be doing a cystoscopy to assess for integrity and make sure that everything was repaired. And yeah.
Okay, so we're going to repair the bladder in 2 layers. But can you tell me just basically what layers are you repairing and maybe what suture are you using, just very briefly?
Boy, I want to say we start the mucosa first, so the 2ovicral. I'm
Okay,
saying that
that's fine. Sure.
uncertain. I believe that's in a running layer, and then you'll do the serosa edges with, I believe, another small one, so another 2ovicral, but interrupted.
Okay, so you said you were closing the mucosa and the serosa. There's a bunch of tissue in between the mucosa and the serosa. Neither the mucosa nor serosa really have any sort of integrity as far as repair. Is there any other tissue you want to incorporate into your layer closure here?
Muscularis.
Yes,
Yeah.
exactly. Yeah. So we're going to 2 layers. So tell me exactly what you'll incorporate into your inner layer and what you'll incorporate into your outer layer, and then we'll move on.
I have to say I gave my best guess with the mucosa and the muscularis and
Okay, yeah. So mucosa, submucosa, and inner muscularis. That's true. And then for your outer layer, what are we doing?
I guess if it's not the serosa,
Yeah, well, the serosa has to be part of it because now we're going toward the outside. So it's
mhm,
mucosa, submucosa, maybe some inner muscularis on your inner layer. What would be your outer layer?
the serosa to the muscularis.
Yeah, outer muscularis and serosa. Sounds great. Good. So we repaired that. And then you said, are we going to do a cystoscopy first, or are we going to complete our hysterectomy first?
Well, if we have not completed the hysterectomy, I would complete the hysterectomy and do the cystoscopy at the end of the case.
Okay. Next question. In the repair of yours, is there any reason why you might want to do a cystotomy right now before you continue further with your hysterectomy?
I'm sorry, do a cystotomy before I continue, did you say?
Cystoscopy. Is there any point,
Oh,
is there any reason why you might want to do a cystoscopy right now, rather than wait until after you've completed the hysterectomy?
well, sure, just when we were talking, I guess that would also be a reasonable approach just because of the unusually large size of the uterus. Perhaps, like we were saying, there was potentially another injury that would need to be repaired while we had the abdomen open
Well,
and before we dissected
right.
further.
That's a great idea. Is there any other reason, given how we've sort of set this up, that you might also just want to check from the inside before you carry on
Check
completing your
the
hysterectomy?
ureteral orifices.
Exactly, yes. So we identified that this cystotomy it's within several millimeters. It's not actually impinging on the ureteral orifice. You just threw a bunch of suture material into the bladder wall, and you couldn't actually see the ureteral orifices while you do it. So the point of caution is you want to be sure that we didn't, with our suture material, we didn't impinge upon the ureters.
Mhm.
So we would do a cystoscopy right away, and we would check. Yes, absolutely. And let's say we do a cystoscopy and we sort of backfill our bladder. It looks actually nice and tight. You're getting some nice jets from the ureteral orifice. Things look good. Now what would you do?
If everything looks good, I would proceed with the hysterectomy.
Sounds good. So we'll proceed with the hysterectomy. You're able to get the big uterus out. You close the vaginal apex. Anything else you would do now before you conclude the case?
I would repeat a cystoscopy at the end.
Sounds good. Why would you do that?
Just due to the assumption that we have such an abnormal anatomy and there's a higher chance for a repeat injury and or other injury, just to make sure.
Perfect. Exactly. This is a complicated case. We already incurred one injury in the course of that. It would be really good at the end after we did a whole lot more operating, and we get remember, we get closer and closer to the ureters the more we go down toward the cervix and the vaginal apex, to be sure that nothing else happened which needs our attention before we leave the operating room. I think that's a very, very wise choice. Good. Nicely done. Maria, that was something I don't think we expected based on this case, but
Nope,
examinations
not
are
at
do
all.
this from time to time. So very nice. So the principal thing is whenever we're operating upon the bladder with hysterectomies, whether it's vaginal or abdominal or laparoscopic, really where we get into trouble with the bladder is where we're actually working directly on dissecting the bladder, and that's always at the trigone, because where the cervical vaginal junction is, remember the ureteral orifices are usually around the level of the internal cervical os. So they're a few centimeters up from where the cervix is in the vagina. That happens to be right where you're dissecting that endopelvic fascia there. So you're going to be right near the trigone usually when we make a cystotomy. And the immediate concern is there anything that's problematic for the ureters right now? And you could actually, in a case like this, because you got a fairly good cystotomy, you could actually stent the ureters right through your cystotomy with your urologist if you just wanted to pass them up and follow up the pelvic sidewalls and be sure that you were good and be sure you're getting good urine from them. Or you could examine it, close your bladder, and then go and do a cystoscopy to be sure things still look good after your repair. I absolutely agree. At the end of any case like this where you do an intraoperative cystoscopy, you should do a cystoscopy at the end, just because you've operated now on how many more points we had. I don't think you said you'd gotten the uterines yet, so we got 3 more points at which we could have caused a ureteral injury, where we're taking the uterine artery pedicles, where we're doing the uterosacral and cardinal ligaments, where that's in that paracervical web tunnel, and then at the vaginal apex where you're getting your angles of the apex ureters are very close to there. So we're operating on multiple sites where the ureter could be injured. I agree absolutely with what you said. Nice. Is there anything you'd like to ask about, or anything
I
just
do
further you'd
have
like to talk about with this case?
2 quick questions.
Or,
I've
yeah,
been
sure.
listening to boards previously, and they talk about how the area of the bladder that's injured is more common in one area during an abdominal hysterectomy versus a vaginal hysterectomy. Do you find that that's something that I can't recall if that's like
Sure.
wrong with the
Well,
bladder during abdominal and then the trigone for vaginal hysterectomy,
Well,
or?
when you're doing a vaginal hysterectomy, you're dissecting from the inferior aspect up, so you're really in the trigone there. If you're dissecting down onto the trigone, you're above the trigone with an abdominal hysterectomy. You're kind of below, coming up on the trigone when you're doing a vaginal hysterectomy. So it's simply because of the direction in which you're dissecting. You're
Okay.
going from the inferior side of the cervical vaginal junction up with the vaginal hysterectomy. You're coming from the top side of the cervical vaginal junction down, and there's a couple of centimeters of sort of tissue where the cervix and the bladder are sort of opposed to each other.
So is it true that those are the 2 more common places for each to have the more common injuries, or is it always a
Yes,
trigone? Okay.
yes, but in either case, you're either going to be below or at the trigone, or above or at the trigone. So it's the trigone no matter what. The dome of the bladder is like way up, where you've got your bladder blade retractor into the bladder on your self-retaining retractor. That's the dome of the bladder. You're always way down below that. You're close to the trigone no matter what.
Okay.
Which is why this is always a standard discussion.
It's always a what?
It's always a standard discussion because no matter what, you have to be concerned about the trigone and the ureteral orifices.
Okay. And then I was anticipating, if urology wasn't available and I had perhaps transected the ureter, do I say that I can do a stent even though I don't know how, nor would I normally, or that I just know that I could?
You only in the exam discuss doing things that you actually could do in a real situation. So if you need somebody to help you with that, you get somebody to help you with that.
Okay.
No problem.
Okay.
No problem with that at all. Never.
Okie doke.
Good work. Thank you. That was actually a really good discussion to have. Thanks. Let's go to Dr. Delara. Let's get Richie for a minute. And I think Maria. Did you have another question? Maria, are you there?
Nope.
Oh, okay. I'm sorry. I saw the raise your hand go back in. No problem. There's Dr. Delara. Hey, Richie, let me get out of here for a minute. Can you hear us okay?
Yes, can you hear me?
Oh yeah, we're good. Thank you. Let me just get down to your case list here, right here. Anything in particular you've been looking at that you'd like us to talk about this evening?
No, nothing in particular.
Do you have a preference for OB/GYN or office practice?
We can do GYN.
GYN, okay, coming up. All right, let's see what we got here. Do something different than what we just did about that. Let's see. Let's do something down here. Let's see, got hysteroscopies, fibroids again. Let's see what we got here. Lots of endometriosis. Let's see here. Can we talk about case number 17 on your GYN cases? This is under endometriosis.
Sure.
Let me get you right like that. So, 20-year-old nulligravid patient. You have pelvic pain, abnormal uterine bleeding, dysmenorrhea, and failed medical management. And you are doing a laparoscopic excision of endometriosis. So I think a first question is, you're working up this pelvic pain, and you've decided to do a laparoscopy on this patient. What would you say is your differential diagnosis as far as the etiology of the pain going into the laparoscopy in this case?
Going into the laparoscopy, I would be, I guess my differential would include gynecologic, gastrointestinal, genitourinary. In terms of gynecologic, I would be concerned about endometriosis, adenomyosis, potentially fibroids. In terms of genital urinary, I'd be thinking about something like interstitial cystitis, and then gastrointestinal, any type of maybe constipation or any type of appendiceal pathology.
Okay. So as an examiner, I think an examiner at this point would think that we're doing a laparoscopy in this patient, but we haven't really settled on this is likely gynecologic pain. It sounds like we're still working in other compartments. So I think an examiner might ask you, can you diagnose interstitial cystitis or constipation based on a laparoscopy? Your answer obviously is no. I think what the examiner would ask is, so why at this point are you deciding to do a laparoscopy on the patient, given that you're not really sure this is gynecologic pain, and the laparoscopy will only help you with certain types of gynecologic pain? Why not? So why not do more of a workup before you do the laparoscopy? Why'd you do the laparoscopy now?
Correct. So this patient had evaluation by other providers, and she's tried other forms of medical management without relief of her pelvic pain.
Yeah.
So at this point, I think it would be reasonable to evaluate the patient for endometriosis. I think that was at the top of my differential.
Got it. So that's so if we made a list of the top 3 or 4 things, what would be maybe the top 2 things on the list as far as what you thought was going on here?
Sure. So I would be considering endometriosis or just dysmenorrhea or adenomyosis.
Sounds good. So now what we come down to is the top things on your diagnostic list are in fact gynecologic, which is kind of right, because if your differential diagnosis has stuff that's non-gynecologic above the other stuff, we probably should wait on the laparoscopy. But now that's
Gotcha.
all the examiners needed to hear is that they're interested in where are we placing a laparoscopy in the course of an evaluation of pelvic pain. And first of all, we want to be pretty sure it was gynecologic so we don't subject the patient to an unnecessary procedure. If maybe a GI consult will clear it up. But the second thing is, on the laparoscopy, we need to have a list of things that we could look for, recognizing that laparoscopy is only visual. We do not get any other, tactile information from it. That's what our pelvic exam is for. So we'd need to have some things on the list for which there would be visible findings, and you've described at least a couple of them.
Of course.
If you had a negative laparoscopy in this case, do you have other things that you could then work on coming out the other side?
Sure. So I would, I guess prior to bring her to the operating room, I would evaluate her for things such as myofascial pain. If she has any type of gastrointestinal symptoms, then I would recommend a consultation with gastroenterology for consideration of, other types of gastrointestinal etiologies.
Sounds perfect. But so we're going to go with the laparoscopy. Good. So tell me then briefly, you giving a differential diagnosis, you're doing a laparoscopic evaluation with this patient. What exactly are you looking at? Can you tell me just sort of how your laparoscopic evaluation proceeds?
Sure. So I evaluate the abdomen and pelvis pretty systematically. So I look at both diaphragms, I look at the appendix, and then I run the bowel laparoscopically. I take a look at the pelvis by evaluating the uterus, fallopian tubes, ovaries, pelvic sidewalls, posterior cul-de-sac, and anterior cul-de-sac.
Got it. Okay. How then would you evaluate for adenomyosis with a laparoscopic evaluation?
I don't think I think you can hypothesize if someone has adenomyosis based on visually looking at the uterus, but adenomyosis is a pathologic diagnosis, so I would have to take a biopsy or remove the uterus to make that diagnosis.
Right, so we can do that. And you said your other diagnosis with us, you just had dysmenorrhea. Is there anything that you could see on a laparoscopic exam that would help you to identify that that was the cause of her pain?
No. If I had a negative laparoscopy and she had pain with menses, then I could assume that dysmenorrhea was higher on the differential, but then I would have diagnosed that before I took her to laparoscopy.
Good, sure. So it sounds like endometriosis is the only thing on the list right now for which there might be visible findings that would help you. So sort of what we can find out from this laparoscopy is limited. If she did not have endometriosis, are there other things that you might think of which could be causing her pelvic pain for which there might be visible findings, but we have not yet mentioned them? Anything on a gynecologic examination with laparoscopy that might account for her pain if it was not endometriosis, and that you could actually see with the laparoscopy?
Leiomyoma, potentially.
True. I'm sure that could be too. Sure. Although you probably would have picked that up if you'd done a preoperative ultrasound or a pelvic exam. But yeah, sure.
Yeah.
Yeah, that's true too.
I guess adhesions.
Adhesions, I think that's a good one as well. Yes, you bet.
On a laparoscopy in a gynecologic patient.
Yeah.
I guess you could consider. Could you consider pelvic congestion?
Yes, exactly. We could actually see significant pelvic varicosities. That actually is a documented potential source of pain. That's very good. Anything else? We're getting now we got some good stuff to think of on the exam. So it's not just endometriosis. We're looking for iomata. We would look for pelvic varicosities. That's a reasonable thing to look for. Anything else that you can think of? We're down. I think now we're into stuff that would be a whole lot, statistically less common. But anything else we might consider here?
I mean, I'm not sure. I'm not sure.
That's fine. Then no, I think if you are done, you can, I don't know, and we'll move on. That's exactly how you manage that in the exam. One thing I
Okay.
would keep in mind, just if you really wanted to sort of kind of have a sharp differential diagnosis in the exam, pretty uncommon, maybe one chance in 100 or so. There could be a congenital uterine anomaly, such as a bicornuate uterus, for which people do have actually significantly increased dysmenorrhea in many of those cases, and you might identify that only by doing a laparoscopy. So it could
Interesting.
be
Okay.
a general anomaly of the uterus. That would be way down on the list. Highly unlikely, I think, in a case like this. Good. So
Gotcha.
you did laparoscopic excision of endometriosis, and then you put in a levonorgestrel IUD. What was
Yes.
done very briefly, then what will your ongoing care consist of after you've made this diagnosis and you've done these procedures? What's your follow-up plan consisting of?
My follow-up plan would be to assess the patient at 3 months and see how her pain has progressed after surgery.
Mm-hmm. Sounds good. And if at 3 months out, even despite you putting that IUD in, she's still having symptoms that are not appreciably different than when you started, where might you go from here?
I would probably reevaluate her in the office and see if there are other pain generators.
Okay. Such as, what are you thinking there?
Probably like maybe she has persistent myofascial pelvic pain. Maybe there was some sort of bladder symptoms that I missed.
Okay.
And she does, and she may have interstitial cystitis or some sort of gastrointestinal.
Okay. If her
source.
pain seems to be, and I'm assuming this was cyclic pelvic pain that made you think of endometriosis, and it's persisting, and the IUD hasn't really changed anything, is there anything you can think of that you might be able to do then to really be able to determine if this is in fact gynecologic pain, and if there's anything better that can be done to treat it? Any intervention or evaluation that you could do at this point?
You could probably offer the patient Lupron
Ah, very good. What you're
to
thinking?
suppress.
Yeah, how might that
Well,
help?
it would suppress the gynecologic aspect of it, and if it was indeed like endometriosis or dysmenorrhea, then essentially that pain would improve or resolve.
Yes, exactly. That is a really useful discriminator. If we're still trying to figure out gynecologic versus not gynecologic, if you give the patient 3 months of leuprolide, seriously, anything gynecologic should either resolve or it should be improved, even if it's pelvic varicosities, adenomyosis, endometriosis, I mean, anything but pelvic adhesions, basically, which you would have seen on your laparoscopy. And if it does not change anything, then we are really seriously thinking about what option, what possibility here.
Can you repeat the question again? I missed that.
So if 3 months of leuprolide should really either resolve or really significantly improve any of the things that you talked about, endometriosis, pelvic congestion, symptomatic myomata, adenomyosis, all that under 3 months of lupron should really, really get better. If there is, and if that's the case, then you definitely have documented that this is gynecologic pain, and then you have somewhere to go. If there is really no significant change on the symptoms at 3 months of lupron, what would that suggest to you?
Then it would suggest a non-gynecologic
Yes,
cause
indeed.
for her
That's
pain.
exactly it. Good. And then we're going to go other people involved. That's perfect. That was exactly right. That was very nicely handled. So your description of sort of going into the laparoscopy with these diagnostic laparoscopy cases, you do want to have a good idea of a few things for which you could have visible findings. And we sort of listed the things that commonly turn up. And there may be some things for which we would not be visible findings. And we do have a plan for coming out of the laparoscopy if it's negative. And if there's any confusion that using GnRH agonist suppression for 3 months that's a very useful test for gynecologic versus non-gynecologic. And that's a nice thing to be able to talk to the examiners about. Very well done. That was a good discussion. That was, I think, some really thoughtful and sharp management there. Nice work. Is there anything you'd like to chat about, or just kind of questions on this case before we move
on? No questions about it.
I think we're happy. Thank you for sharing that with us.
Okay.
Nicely done. Let's see. Let's go ahead. Anyone else who would like to participate? Dr. Jones had her hand raised just a few minutes ago. We'll go check on her in a minute. There we go. Ebony, let me get you unmuted here for a second. Get out of here and go to your case list while I'm just waiting to unmute you here. There we go. Get you there and get you there. Well, I'm trying. Let's see. Ah, there we go. Ebony, hey, thanks for joining us. Can you hear us okay?
How you doing?
Hey, good. What would
I
you like to
can.
look at this evening? Anything at all in your cases that you'd like to look at with us?
There's an OB case that I kind of want to
Sure.
go
Sounds
over.
good. Let's go with that.
Um,
Direct me to it and we'll pull it right up here.
I have changed my list since this one, but
That's okay.
it might
That's
be the last one.
last case. That is pups.
No,
Cholestasis.
not that one.
Cholestasis, no.
No, the 80 case number 84.
84. Oh, good. All right. I'm going to park her right here. Good. All right. 26-year-old. Let's see, at 39 weeks. Let's see. It looks like postpartum readmission for acute abdomen and intra-abdominal abscess. Wow. Oh my goodness. All right. Let's see. So what should we talk about on this? There's some stuff going on here.
There's a lot.
Yes. Yeah. What should we take on this evening in this one?
I'm not sure. I guess I'm just a little nervous about having to explain her readmission and then having to do an exploratory lap / hysterectomy.
Oh, of course. Yeah, no, I know. I understand. So it looks like, so she had a successful TOLAC and she had a VBAC, it looks like, which is actually great. And it looks like she otherwise did fine. Did she remain in the hospital during this time then with the recognition?
No, she went home.
Complication? Oh, she went home and then she came back. Got it. Okay. How far out was she when she came back?
She came back on postpartum day 10 to the emergency room.
Wow, got it. So if she shows up, here's a good thing. When it shows up in an acute abdomen, then at post-op day 10 from an uncomplicated vaginal delivery, what would be your differential diagnosis if the ER physician is asking you to come and see the patient, given what we know about her so far?
Well, knowing that she had a history of a prior C-section, one of the things high on my differential was a potential of a uterine dehiscence or rupture, and infection. Definitely endometritis, postpartum endometritis was on my differential as well.
Yes.
I was also thinking of, she wasn't bleeding on admission, but that was also on my differential if she had had significant bleeding at home, and maybe was bleeding into her abdomen. And of course, concerns as well as the possibly a hernia and incarcerated hernia is on my list as well.
Okay. Anything else as far we're talking about sort of stuff that might be directly related to delivery? Anything else that you would add into the list that might be going on here?
I guess since she had a vaginal delivery, there's a concern that there might be retained products.
Sure, that would be
but that would lead to infection.
Absolutely too. Sure. So based on that differential diagnosis, when you're seeing in the ER, what would your exam and workup consist of? Just if you can walk us through the basic steps.
I would do a history of physical exam on her. First examining, see what she was experiencing at home that brought her into the emergency room. Examine her abdomen to see if it was tender or distended. See if there was any signs of what was causing her significant abdominal pain, and then do a vaginal exam.
And what would you be looking for on the vaginal exam?
I would look to see if she had any vaginal repairs that could possibly have been infected or broken down, to see if she was having any bleeding or abnormal vaginal discharge, to see if possibly there was some other abnormal pathology going on.
Sounds good. And if you couldn't see anything otherwise on an exam, what would your testing consist of? Where would you go first?
For lab work, I would get the basic lab.
Sure.
So basic labs, but if I was doing a vaginal exam, I definitely would collect cultures, do a urine exam or urinary culture on her as well, vaginal cultures, and then do blood work to see if her hemoglobin dropped and where her white count was as well.
Sure. Would you get any imaging on her?
She got a CT scan as soon as she got to the ED.
What did that actually show?
Excuse me?
What did that actually identify?
It showed an intra-abdominal abscess, or what was perceived to be an intra-abdominal abscess.
Oh,
And pelvic abscess extending from her uterus to her right adnexa.
wow. Okay. So based on that finding, how would you counsel this patient? And if you're doing an informed consent with her, what would be the potential surgical procedures that you would now be listing for her?
I would consent the patient for an exploratory laparotomy,
Yep.
discuss with her that we were going to go in just to exam and see what was going on, but that there was a potential that she could have a hysterectomy and or bilateral salpingo-oophorectomy. I counseled the patient about what that meant and that it would mean that she wouldn't have any more children potentially. I also counseled her on the risk of needing a blood transfusion and a prolonged hospital stay.
Mm-hmm. Right. What type of surgical incision would you make here?
For this patient, I did a midline vertical incision.
Sounds wise. Good.
And I counseled her about that as well, even though she had a fin and still incision previously.
Yeah, no, sounds wise. So when you're examining the abdomen and the pelvis here in a case like this, how then do you determine whether a hysterectomy needs to be performed? What particular criteria or findings are you looking for on your detailed evaluation in here that determines whether you're going to do a hysterectomy or whether you can manage this without doing a hysterectomy?
Several factors. I think the biggest is, what does the uterus look like tissue-wise? Is it bleeding? Does it look infected and necrotic? And that was the biggest issue with this particular patient. The uterus was just very significantly infected and was breaking apart throughout the procedure.
Wow. Okay. So based on that, do you have any sort of thoughts as to the underlying cause of this? Because that is certainly very unusual.
Yeah. So while the case was occurring, I was worried that the patient had obviously an infection, but
Yeah,
I
sure.
was thinking in my mind, we had strep pyogenes, and I was concerned that if I didn't remove the tissue, then it would be life-threatening.
Yeah.
And then on my differential was potentially that at the time of her vaginal delivery or shortly afterwards, that she had an undiagnosed uterine rupture that then caused an extending infection into her abdomen.
Got it. Okay. So then following this procedure, given that diagnosis, what would your antibiotic coverage of her be? Since you've listed antibiotic treatment at the bottom there.
Mm-hmm. We covered her broadly for anaerobic as well as typical vaginal cultures or bacteria. So she was initially on ANSAF when she came in. That's what they started her on in the emergency room. And then we transitioned her to, oh, sorry, I just lost my I think it was, I'm drawing a blank, but I will know that when it's time for me to prepare this case.
Okay. Is there any other testing you would get in this case? Once you realize you're doing a hysterectomy, you're completing a procedure, any other testing or evaluations that you would get based on your findings in the OR here? Aside from
We got
obviously
cultures.
yeah, what kind of cultures did you get?
We got cultures of the uterus as well as the adnexa. And I did, and she got vaginal cultures in the emergency room as well.
Would you get any other types of cultures?
She got blood cultures as
Yes,
well and urine cultures prior
that's
to
what
going
the
back to the
examiners want to
operating
hear.
room.
Definitely, we're evaluating her for bacteremia in this case. That's exactly what they'd be waiting to hear. Perfect. This sounds like an extraordinarily unusual case. My goodness, how did she do?
She's great.
Wow, thank heaven for that.
I just ran in her chart to look her up a little bit more, and she just had an abdominoplasty. She's living her best life right now.
Goodness. All right. No, in a case like this, there's the differential diagnosis of acute abdomen, which would have some things in it related to probably her delivery, and perhaps some other things. I mean, we might want to mention appendicitis. You could mention any of the other things that commonly cause acute abdomens in there, and I think your labs and your imaging would probably be more revealing mostly than examination. And then they would want to know if you decide to operate on a choice of incisions that you have maximum exposure would be really important. And then basically how do you decide whether you can just operate conservatively or whether you need to do a hysterectomy? And I think we went through all of that. So I think we've covered anything really that examiners could possibly ask you in the exam with regard to this case. That was a really extraordinary discussion. Is there anything you'd like to talk about this case, or anything we should be thinking of other than where we took this?
The only thing that I was also a little worried about is the CIN3 on the pathology, and whether or not they would, ask like that. I wasn't thinking about cervical pathology prior to doing the procedure, but then just having, plans for follow up for her.
Yeah. How would you follow her up?
Well, due to the high dysplasia, she probably would still need to get vaginal apex pap smears.
Yes, she would.
Routinely.
Yes, yeah, because she clearly has HPV. Yes, you would want to follow her up that way. Would anything else be required?
If the pap smears come back abnormal, you could do a colposcopy as well.
Sure. Yeah, but in addition to doing the cervical cytology of the vaginal apex, is there anything else that might be required, or would that do it for
you? Cytology with co-testing.
Well, you would. Yeah, I'm sure they would do that. Yeah.
I don't think I would do anything different.
You removed your entire cervix and uterus, so you pretty much took care of the problem that presented itself here. So it's cytologic follow-up. I agree. I don't think there's anything else to do.
Okay.
I think that's that. Good. Boy, that was a surprise. Thank you for sharing that with us. That was really an interesting case to discuss. Good work. Let's cruise on. Let's let Ebony take a rest after all that. We have some more time. Maybe Dr. Herzlich or Dr. Pham, if either one of you would like to. Thank you, Dr. Herzlich. Let's get to you just a moment here. Let me go and find your case list for a moment. Right there, and let me get you unmuted. Trying. Let's see there. Still trying, Dr. Herzlich. I think you might have yourself. Oh, there we go. We got you. Can you hear us okay?
Hi, good evening.
Hey, good. Thanks for joining us. Is there anything on any part of your case list that you'd like to talk about? We'll kind of go anywhere you'd like.
Let's try OB. I don't have anything in particular, but
sure, that sounds good. Sure. OB. All right. Let's see. And anything particular on the case list, or should we just pick something at random?
You can just pick something random.
Okay. Let's see. Let's go find something sort of completely different from what we talked about so far. Let's see.
I don't have anything exciting like that.
No, that's okay. The examiners are going to spend your half hour talking about really unexciting stuff mostly, because all of us have bread and butter obstetrics, and we always want to think about that. Could we talk about maybe case number 12? This is a patient who is 39 weeks, gravid 5 pair 3. She has a history of a stillbirth at 34 weeks. And so now she's in her subsequent pregnancy and she's being evaluated. Do you have any information, or are you aware of anything about her workup at her prior stillbirth? And if you don't have any information on it, that's fine.
No, I saw her for the first time for this pregnancy. And yeah,
good.
She didn't have much information. She was also not the best. She was not very consistent with follow-up, so did not have a lot of information about this stillbirth.
Sure. That's okay. On your first obstetrical visit, though, when you elicited this history of the stillbirth at 34 weeks, what would you want to ask her? What information would you want to get on a history that might be helpful for you in this pregnancy?
So, of course, taking thorough history in regards to any past medical history, diabetes,
good.
Any any history of autoimmune diseases such as lupus,
Good.
APLS, any history of any substance abuse, any trauma, any genetic issues or anemia. These will be the main thing that I would be looking for.
Sounds good. If she was not really able to provide much information about it and her records were not really available, is there any particular testing or evaluation you'd want to do at her initial obstetrical visit that might help to give you information that would help you in this pregnancy, as far as sort of whether there might be any carryover risk to this pregnancy from what happened to her last time?
Yeah, so the thing that I would recommend will be genetic testing.
What kind of genetic testing are you thinking of here?
I'm thinking of NIPT. I would not recommend anything invasive as a first step.
Good. So we're talking about genetic screening for aneuploidy then, I think is what we're talking about. That sounds good. Good. Anything else you'd want to look at here as far as just testing you would suggest for her?
Depends on her risk factors. I would also recommend doing early GCT to see if any diabetes.
You bet. Absolutely. Yes. Anything else?
I would want to know if there are any history of infections. So I would test her for any infections, gonorrhea, chlamydia, HIV, syphilis.
Good. Sounds good. Anything else you'd want to assess for? And you mentioned there when you were talking about the possible causes and information you want to find from the last pregnancy, you mentioned something for which maybe we would think about testing in this pregnancy if we didn't have information about
it. If you're referring to antiphospholipid syndrome?
Yes, exactly. Yes.
Yes, so I can send antibodies for to see if there are any signs of any antibodies consistent with antiphospholipid syndrome.
Sounds good. What test would you order if you were thinking about that?
So I would test her for cardiolipin, glycoprotein beta 2. I would test her for lupus antigen.
Would you do all of those tests?
Yes, I would.
You only need to do one. You have exactly the right test. You've described actually the 3 most common tests that are used to test for APLS, but you really only need to pick one and test it. And if you were to pick one, is there one of those 3 tests you mentioned to me that you would prefer?
I would do the lupus antibody anticoagulant.
Anticoagulant? Okay, that sounds fine. Sure. If that were negative, what would you do with that information?
I would think she has a low suspicious for this.
Sure, that's good.
Of course, I would ask for any other history of any other miscarriages or
that's fine.
Family history of.
Yes, that's true. I think family history also. If your lupus anticoagulant test was positive, how would you manage that information?
So in order to be diagnosed, she will need another test.
You betcha. Yep. Yes.
As a diagnosis. But given the high suspicious and the poor obstetric history, I would not wait, and I would refer her to MFM consult to see if there's anything else recommended in management. At this point, I would not start her in anything prophylactic.
Okay. When would you? You said you'd have to test her again. When would you test her again?
I would need 12 weeks apart.
12 weeks, that's true. So we're waiting about 3 months or so. So if she does have APLS in this pregnancy, would you be comfortable waiting 3 months to get that test back to determine whether she needs to be treated?
No, I would not feel comfortable. As I said, I would get a MFM consult earlier than the time I can give a diagnosis, giving the high suspicions and the history.
Okay. If an MFM consult were not available to you, just empirically, how would you manage this case? You have this history of the stillbirth. You have one test that is positive for APLS. Other than repeating a test in 3 months, so if you were the only one available to manage this, what would you do?
So I would have a conversation with the patient. I would share with her that at this time, because based on criteria, I cannot diagnose her with antiphospholipid as a title, but given the high suspicious and you know, the risk to have it recur, I would recommend her to go on prophylactic anticoagulation.
Good. I think that's absolutely right. And you can feel free to manage that yourself. You can certainly get MFM on board, but if they're not immediately available, that's a decision you can make by yourself. And given her history and the low risk of really doing prophylactic anticoagulation and your considerations for her, I think it's absolutely appropriate to start anticoagulation while you are then waiting for the test, the follow-up test. Now, just to finish up here then, let's take the APLS off. Let's say all of her testing was negative, and we really don't know why her previous stillbirth occurred. Is there anything you're aware of that you can be doing in this pregnancy that might actually help you to reduce the risk of a recurrent stillbirth in this pregnancy if you don't know why it occurred last time? Are there any present recommendations about things that we could consider?
Yes. So given that all the workup was found negative for her, we would still want to to find things before anything else happened. So I would recommend antenatal testing, and I would start it around 32 weeks to have her do NST-BPPs. And I would have her do growth ultrasound. I would not wait. Sometimes around 30 weeks, I would have her do a growth ultrasound to see if there's any signs of FGR and other abnormalities.
Great, and that's, I believe, exactly what is in the practice bulletin, the consensus opinion from last October on management of stillbirth, is doing growth ultrasounds, and certainly 28 to 30 weeks wouldn't be unreasonable. And if there's a stillbirth that happened after 32 weeks, it's recommended that you may counsel the patient, you may do antenatal testing, and you would start at least 2 weeks before the time at which the stillbirth occurred. So we're talking about 34 weeks in this pregnancy. And that's exactly right. Are there any other options that you, according to the information available to you, you're aware of that you could counsel this patient about as far as any other managements in this pregnancy? Is there anything about timing or mode of delivery that you could consider with the patient if after discussion with her?
Yes, so that's another thing, especially with patients who have a history of stillbirth. Definitely a third trimester, there's usually a lot of anxiety around the pregnancy.
Sure is.
So I would have a discussion with her about an induction of labor, and I would do that anywhere from 38 weeks to 39 weeks, of course, giving having the antenatal surveillance starting earlier.
Yes. So you said you would induce her at 38 to 39 weeks. So would you call this a medically indicated induction of labor or an elective induction of labor?
I think I can call it medically indicated, given the poor history.
Well, you could theoretically, and there's bringing up because the obstetrical care consensus says that although it says specifically although there's no documented medical benefit of delivering this patient early, before maybe 39 weeks for elective induction. It does allow in this consensus document that for patients who have significant anxiety about this, it is reasonable after counseling and shared decision making, what they say, that you could offer delivery as early as 37 weeks. But they make it very clear in there that there's no clear evidence that that actually confers a benefit to the outcome of the pregnancy. You are doing it after decision making with the patient in discussion that there is not clear benefit. But ACOG would actually, it's one of those instances where they would actually be okay with us inducing prior to 39 weeks without a clear medical indication, because we don't know why the stillbirth occurred. And if you have normal growth ultrasounds and you have normal antenatal testing, there isn't truly a medical indication. So I was active about that. It's a great, it actually is an elective induction of labor because it's after counseling of the patient in the absence of any real demonstration of benefit. You are doing it based on sort of history and suspicion. I think you would actually have to call it on your case list if you put it down here, an elective induction of labor. But it is something that is specifically okayed by ACOG now. And it's, I think, one of the only instances I'm aware of where they are okay with us doing induction of labor prior to 39 weeks without a clear medical indication for it. But they are. So that's good. I think you handled that very well. I think that's exactly the right thing. You acknowledge that there isn't a clear medical indication, but you're doing it based on your concerns and the patient's concerns. And if the patient has really serious anxiety about it, it's allowable. Good. Good. I think that was the important thing. This has really sort of opened up a bit in the past several years. The last practice bulletin on this actually suggested that there was really no known intervention that could reduce the risk of recurrent stillbirth. And now they're recommending that we do a growth ultrasound, that we consider starting antenatal surveillance at least 2 weeks before the stillbirth occurred. They're actually starting to change their opinion on this. Good. Nicely done. Thank you, Avi. That was actually great. Is there any aspect of this case otherwise that you'd like to talk about before we have to close down in just a few minutes?
No, I think this was great.
That was a good discussion. I think we hit all the high points as far as sort of what you did a really nice job with, sort of what we would want to find out if we could about the various causes. And we went through sort of all the different categories of what could be going on as far as maternal and fetal etiologies or risk factors. And then the testing, I think you hit all the stuff. Diabetes should be really at the very top of our list. We would definitely want to be sure we had really good gestational dating. A screening for aneuploidy is really important. And APLS is definitely one of those things that you really would want to talk about with the examiners. And then it's really about, if you don't find anything, just sort of discussing with the patient the options, and it's optional antenatal surveillance and it's optional delivery prior to 39 weeks. Good. Very nicely done. Thank you for sharing that with us. That was a nice case. We've had 4 out of 4 nice cases this evening. Thanks. So we do need to stop for this evening because it is actually 9:30 Eastern time. Thank you to all 4 of our candidates who have shared. Those are actually 4 really nice case discussions this evening. Tomorrow we'll be with one of our other faculty. Will be structured cases, as we always do on Monday and Wednesday. Just as a reminder, these sessions are of course all archived at ExamPro. As subscribers, you may come back and review them again and listen to them at any time between now and your examination. We encourage you to do that, just as you'd like to check out specific cases or discussions. But otherwise, we'll meet up again tomorrow evening. Thanks for sharing with us this evening, and have a very nice rest of the evening.